gives me a great pleasure to be here in this beautiful country. I've been coming to the Emirates for the last 20 years and have been witnessing first-handedly this incredible renaissance in medical care and medical education and research coming from this beautiful country. I've been seeing an expertise from coming from all around the world, contributing to the welfare of this country, and a new generation of young and coming specialists, ophthalmic specialists from the Emirates that are changing the face of care provided for the patients. I've been asked to speak today about the issue of myopia and glaucoma. And immediately when Stephen started his presentation, I pulled out my laptop and prepared myself to take out half of the slides. But he was very kind enough not to steal away my thunder, as he put it. And I have only modified my presentation slightly, and I would like mainly to focus on high myopia rather than myopia by itself, because myopes are a big percentage of this planet's population anyhow. But it becomes very tricky when we speak about high myopes and glaucoma, and I'll try to explain why. And to help me explain why, I take you with me to my clinic. I work in the University of Geneva. It's a tertiary care center for glaucoma. We get a good number of glaucoma patients from the west of Switzerland, as well as from the north of France and the north of Italy. And most of the cases that fall into our lab are usually not the straightforward cases, as you can imagine. So this is a lady that is a 67-year-old. She's a high myope. She was minus 18 in both eyes before having a phaco for both eyes. She then developed a retinal detachment in the right eye and unfortunately lost this eye. So she is now a single eye high myopic patient with glaucoma. On maximal medical therapy, her pressure has been around 17, 18. She has a pachymetric values within normal, an axial length of 31 millimeters, and this is her fundus. It's not a very pretty image to look at with all those myopic maculopathies and chorioretinal atrophies, and this is her fundus. And this is her optic nerve head, and it is, as we say in French, casse-tête chinois. It's very difficult to determine if it is glaucomatous or not. The visual field looks like that. It's, again, a very pessimistic look. But with this kind of visual field and with a vision of 0.3, she tells me I can do everything except drive and play tennis. She has a very decent quality of life, and she wants to sustain this vision that she has. We have a sequential visual field evaluation for her, but I mean, in such an advanced situation, visual field changes are very difficult to document. OCT with a significant loss of tissue, and with the flooring effect of OCT, and with the morphology that is very particular in myopic discs, all imaging techniques, in my opinion, become of a very limited value. But we need to look, as we do for every glaucoma patient, for pieces of the puzzle. Pieces of the puzzle include disc morphology, includes imaging if possible, includes visual fields, but includes a lot of information that we need to pick and look for every particular patient. One of the most important indicators or most important pieces of evidence that I look for is the maximal pressure before starting therapies. It's very important to record before you start medications what was the highest pressure reached, and correlate that with pachymetry to see if the patient would fall into this theoretical bracket of high-tension glaucoma versus low-tension glaucoma. One other thing is also to look very carefully for vascular risk factor. Is the patient associated with systemic hypotension? Does she have migraines? Does she have vasospasticity that you can document in the form of Raynaud's phenomena, for example? And finally, when we look at the intraocular pressure is not just maximal and minimal, but it's also the range of fluctuations of intraocular pressure over 24 hours. So it is of an extremely important value for you to record the pressure multiple times throughout the whole day. And this patient has on maximal medical therapy a fluctuation of 9 millimeters of mercury, which is pathological. We know that we can tolerate a physiological fluctuation of 4 to 5 millimeters, so 9 is definitely too high. Now, let's look into what we know of myopia and glaucoma. We know that for about 5% of myopes develop glaucoma versus 1.5% of non-myopes. So there's a threefold increased risk of glaucoma, as has shown by the Blue Mountain Eye Study. This specific patient, as we have lost the ability to document or to diagnose even with a visual field or imaging, we have to rely on our clinical sense. And as Stephen rightfully said, it is not just a science, it's an art form, because you are working with all your intuition, mixing that with all your experience and all what you have known as a doctor in general and as an ophthalmologist to try to make a decision if the patient is glaucomatous or not and what kind of management you should offer him or her. So I'm not going to go into details of how to examine a disc. Stephen actually brilliantly showed that, but just to remind you very fast is that we need to determine where the rim is. Look at the peripapillary region and its alpha and beta zones. Look at the retinal nerve fiber layers, and the retinal fiber layer evaluation is something usually abandoned by the ophthalmologists these days. Dilate the patient, fully dilate, and you work with the red free and work at a high magnification and at a high illumination to be able to catch retinal nerve fiber layer defects in early glaucoma. Look for the lamina cribrosa and look for disc hemorrhages. So just to remind you again, determine the scleral ring, and then we actually determine the edge of the cupping, the external edge of the cupping, by the course of the vessels. So at the point where the vessel would kink and would fall into the cup, then you would know that this is your cup. So this is our famous isn't rule. And at the moment where the actual vessel would change course, as you can see here, this would be the margin of your cupping. It seems very simple when you're looking at a straightforward cup, but it becomes indispensable. It becomes your finger of God showing you where the cup is once you work with a myopic cups. Now remember that disc sizes, as Stephen said, can vary, and disc sizes and cupping, big cups happen in big discs, and big cups and big discs can be physiological. What I would like to mention is, again, looking for the vertical and horizontal diameters of your disc with your slit lamp. And then, extremely important, please consider that you have to correlate that with the kind of loop or lens that you're using. A plus 66 or a plus 60 diopter is something very different from a 90 diopter lens. Small, medium, or big can vary significantly according to what you're measuring, that you have to correlate to what kind of lens that you're using. Now, again, we go back to our patient and we ask ourselves, is she glaucomatous or not? Now we determine the scleral ring. We then follow the vessels as they kink, and you can see that there is a huge cupping of this disc. And it is not the red-white differentiation that will show you what is a cup and what is a neuroretinal rim. It is actually following the topography and following the vessels as they move within the cup and emerge or move within, and at the point of their kinking, you determine if the disc is cupped or not. This is again another example, and you can see it is a widely cupped disc, judging by how the vessels change their direction as they dip into the cup. We mentioned that imaging becomes of a less of an importance because the normative database of those devices first are racially determined. So most of the devices that you have are either on a European descent, or some will provide you an African American descent. And finally, in your population, the normative database might not be that useful to you. Visual fields should not be judged by putting a couple of visual fields in front of each other on the floor of your office and trying to make a good judgment of is the patient progressing or not. They're not even good enough to look at by putting the single analysis of every single one on your monitor, but you have to harness the capacity of the modern automated perimetry and look for all the trend analysis that can be provided by your devices to see if progression is happening or not. So once you have diagnosed the case of a myopia or a high myopia with glaucoma, what do? Obviously, we lower intraocular pressure, we dampen fluctuations. So if the pressure is low at one point of time, but fluctuations are happening, you have to change your medication to something that, or change your strategy to something that will lower fluctuation. Look for systemic circulation. A 24-hour blood pressure would be very valuable to see. I mean, we know for normal pressure glaucomas, as Mohammed has just mentioned, a lot of those patients would have a systemic pressure of 80/50 at 3 in the morning. This is something that has to be managed. Alternative therapy, I'm a big believer in alternative therapy in glaucoma. I don't have the time to show that today, but I can show you results from a study where we compared contrast sensitivity in normal pressure glaucoma on patients being put on dark Swiss chocolate versus white chocolate, and to show that after 6 months, the contrast sensitivity improved significantly with patients having dark Swiss chocolate. And now, finally, you can always go into surgery. But what type of surgery? Of course, trabeculectomies have a high potential for hypotony, choroidal detachment in those cases, or God forbid, an expulsive hemorrhage. So tough cases, and you have to be extremely aware that if you do a trabeculectomy in those cases, hypotonies should not be allowed at any expense. So even if you get a higher pressure initially, you can always do suture lysis, you can break stitches, but a hypotony in the early postoperative period is a definite no-no, and you have to instruct your patients not to bend, not to strain, not to carry heavy stuff, because it's not a happy situation to see a choroidal detachment or a choroidal or an expulsive hemorrhage. We have published our report on 30 patients with deep sclerectomy with collagen implants in high myopes. Results were decent, were comparable in general to what we get with a trabeculectomy. We get hypotonies in the first postoperative day after deep sclerectomy in the range of 4 to 8.
Sorry, your time has beaten you really by quite a few minutes. So.
30 seconds.
Yeah.
But in all honesty, I've been given 10 minutes where everybody got 15.
Some of the talks this afternoon only have 10 too, so we do have a bit of a cut-off here. So
1 minute exactly. So finally, the take-home messages are, those are difficult glaucoma patients. Your mainstay is to depend on the optic nerve evaluation, to document the stability or progression if you can, but in advanced cases, it's better to intervene early if you cannot wait for progression to happen, because if progression happens, you would lose what is left, lower pressure and operate, and consider also early cataracts, because early phacoemulsifications would also reduce intraocular pressure. Thank you very much for your attention. Thank you.